Hi, everybody. Thank you so much for joining the Fight Colorectal Cancer webinar. My name is Sharon Worrell. I'm the Senior Manager of Education and Research here at Fight CRC, and we're really excited to have you joining us this morning. Today, we're going to be talking about treatment side effects of the skin. And per usual for all of Fight CRC webinars, please feel free to ask questions in the panel on the right side of your screen. And we'll be answering those questions both throughout the session and at the end of the webinar. You can watch the recording of this webinar on the Fight CRC website. You can visit fightcrc.org later this afternoon or tomorrow. And of course, if you did register for the webinar, you'll be emailed a direct link to the recording tomorrow morning. If you have Twitter, please tweet along. You can follow us using the hashtag CRCwebinar. Fight CRC offers a wide variety of resources for all those touched by colorectal cancer. You can visit our website to view, download, and order the latest resources. The information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you are ill, please see a doctor immediately, and in an emergency, call 911 or go to the nearest emergency room. Fight CRC never recommends or endorses any specific physicians, products, or treatments for any condition. And with all of that, we are super excited today to introduce Dr. LeBoeuf. She received her medical degree from the University of Massachusetts Medical School. She completed her residency in dermatology at Columbia University, where she served as chief resident, followed by a fellowship in cutaneous oncology at Brigham and Women's Dana-Farber Cancer Center at Harvard. She is a leader in the field. We are so excited to have her. She's done a lot of work in this area, and I mean, it's going to be an incredible session today. So Dr. LeBoeuf, we'll let you go ahead and take it from here and start your presentation.
Thanks so much, Sharon. Let me get my screen shared for you guys. Let me know if that is working.
Looks great. Perfect.
Great, awesome. So I'm really excited to be talking to you guys today about skin side effects from treatments used in the colorectal cancer setting. And I think anyone who takes care of folks with colorectal cancer and patients and their family members know how significant these side effects can be. I have a few disclosures in that I consult for a few different companies on how to best manage the side effects of the drugs they make, but none of these are relevant to today's talk. And because side effects from cancer treatment are not anything that has been long well studied, there are actually no FDA approved treatments for them. So everything I talk about today and how to manage these side effects is technically off-label. And so again, we don't promote any specific recommendations or any specific medications. This is all based on my experience, and there's no FDA approved treatments for side effects of cancer treatment yet. So today I'm going to just give a brief introduction on side effects from cancer treatment in colorectal cancer setting. I'm going to spend most of the time talking about side effects from EGFR, epidermal growth factor receptor inhibitors, as well as some time talking about reactions that affect the hands and feet, which can be very detrimental to quality of life. As Sharon said, feel free to type in your questions as we go along, and I'll try to field them as much as I can, but then we'll leave some time at the end for questions as well. So with that, I think, again, the importance of the skin in the cancer patient really can't be understated. And this is a quote that was sent to me by one of my patients with colon cancer who was suffering from terrible side effects in the skin from targeted therapies, including EGFR inhibitors. And she was a therapist who said to me, people come into my office looking for unconditional love or complaining that their spouse doesn't offer it. Now I can tell them they already have it. Their epidermis caresses them, contains them, bends any way they like, and asks nothing in return. Maybe we hydrated or protected from the sun, but that is hardly an equal partnership. I will never take my skin for granted again. So her skin was so relevant in her colorectal cancer journey that she would travel here to Boston from out of state and refuse to see her oncologist unless a member of our dermatology team could also see her. So we understand at the individual patient level it's important, but if you actually look across drugs in the cancer setting, this is a long list of drugs that are both targeted therapies, immunotherapies, and you say, you know, how often do skin rashes affect patients on these drugs? The green bars represent any rash at all, and the purple bars represent severe rashes. And what we can see when we look at the colorectal cancer setting actually is that drugs that are used to treat colon cancer commonly cause problems with the skin, hair, and nails. Some of these drug classes cause rash in 80% of patients. So 4 out of 5 patients treated will actually develop a rash. And some drug classes actually cause issues that are considered severe, and that can lead to dose interruption or treatment interruption and impact quality of life in 1 of 5 patients treated. So these are significant. It's a big scope, this problem. We also know that specifically with EGFR inhibitors in colon cancer, that when you get a rash, you know, these are 3 different studies here. When you get a rash, it's associated with doing better from a cancer perspective. It's associated with better progression-free and overall survival. So when you are on an EGFR inhibitor and you get a rash, it means that the therapy works better and you're likely to live longer. The worse the rash, unfortunately, the better the response to treatment. And very importantly, and I think this is key to talking about how we take care of our patients, treating the rash does not reverse the benefit. So you don't have to suffer with the rash to get the benefit of the drug, but the patients who develop the worst rashes are the ones who are most likely to get the best response. So they're the patients we really, really, really want to keep on therapy whenever possible. So the last thing we want to do is say, boy, you got a terrible rash from EGFR inhibitor. We're going to stop EGFR inhibitor and not give you any more because we know that you're the most likely to benefit from that class of drugs. We know the same thing is actually true for capecitabine or Xeloda, which is used in colorectal cancer. These are funny survival curves here that basically show us that the likelihood of progression and overall survival actually is associated with whether or not patients develop hand-foot syndrome. So those who get hand-foot syndrome with capecitabine live longer. So again, skin side effect, better response to treatment. And we also know from lots of data in the literature that if you are on a targeted therapy, you are going to get more side effects in the skin, hair, and nails than those on regular old traditional chemotherapy. And we know that when you develop these side effects, you suffer with symptoms. We know that it affects patients emotionally, and we know that it impacts daily function and daily activity. So these are really robust quality of life studies that show that EGFR inhibitors and other targeted therapies dramatically impact patient quality of life. So because of this, a whole group of dermatologists have sort of gotten together, and we've acknowledged that dermatologic side effects are common in the cancer setting and in colorectal cancer specifically. They are costly to patients. They cost money out of pocket. They cost time. They are associated with better cancer outcomes, but again, they affect well-being, privacy, and quality of life. So the good news is patients are not alone. And in response to this, an entire subspecialty of dermatology has been developed just to try to do research and understand these side effects and to make improvements in patient quality of life so that patients are not only living longer with their cancer, but they're living better. And that field in this paper here is called supportive oncodermatology. Here at Brigham and Dana-Farber, we actually have a whole team of dermatologists who now are available to see patients urgently. But I will tell you, we've trained a lot of residents and fellows who are out there in the country, in the world, working closely with their oncologist to help manage skin side effects. So they're out there, they're interested, and everyone's excited to help patients have better quality of life and stay on their therapies longer. So with that, I'm going to jump right into the EGFR inhibitor associated side effects. Let me see if I can see this here. All right. Hey Sharon, I can't see the chat, so if anybody has a question, will you just, oh, I found it. Let me know.
Yep, absolutely.
Okay. Thank you. So epidermal growth factor receptor inhibitors. So that, as the name implies, epidermal is the term also used to describe the skin. So the epidermis is part of our skin, and EGFR inhibitors, or epidermal growth factor receptor inhibitors, therefore impact the skin quite significantly. We know that this class of drugs is among the most well-studied in oncodermatology. And so what we know about these drugs is that they cause inflammation of hair follicles in just about everybody. They cause patients to have such severe dry skin it can lead to eczema. And they cause an overgrowth of a particular bacteria called Staph aureus on the skin by disrupting the skin barrier, which is very similar to what happens in children with bad eczema. And they cause a specific sensitivity to sunlight. If you take a look at the photos that I'm sharing with you on the screen here, the eyebrow on the top right is actually a breast cancer patient who was treated with an EGFR inhibitor for almost a decade and suffered with brittle hair and inflamed hair follicles, but she didn't want to complain about it because the drug was working so well for her cancer. We were able to take care of that side effect very easily with a shampoo and a topical steroid. But you can see here from the other photos that inflammation of the scalp can be quite significant. You see the patient on the lower left corner that the parts of the skin that are exposed to the sun are bright red and have those little bitty pimples on them, and that the flaking and dryness of the skin can be quite significant. So I'm going to jump into these side effects a little bit more and share some photos so we can talk about how these side effects can be tremendously important in patients' lives. The acne-like or papulopustular eruption from EGFR inhibitors is one of the earliest side effects. It usually does start within 2 weeks of initiating therapy, and patients who haven't had acne since their teens or throughout their life find it to be tremendously important because it invades their privacy. So when you suddenly develop these pimples all over your face, people know that something is not right. And so one of the biggest issues that many patients have with it is that now everybody knows something's wrong. They've been perhaps living with early stage or even metastatic cancer for quite some time, and now their skin is telling the world there's a problem. In patients who have skin of color or darker skinned patients, this can be even more of an issue because everywhere that they get a little pimple, they're left with a dark pigmented stain or post-inflammatory hyperpigmentation. So we like to be very aggressive in patients so that they don't have to suffer with these side effects. So here's one example of a darker skin patient with papulopustular or acne-like reaction. Here's another woman who had it mostly around her mouth, which is a condition that resembles perioral dermatitis in children, but again, an acne-like reaction. It can be more inflammatory or cystic, like traditional cystic acne. While it mostly affects the face, it can affect the trunk as well. In this case, it was very extensive on the front and back of the trunk, pretty severe acne-like reaction. When it does affect the trunk, it usually is more mild. So here you get the sense that it's more upper trunk, more like the pimples that you might remember from teenage years. So importantly, this is not acne. This is, again, an inflammation problem rather than a true acne problem. And that's why we tend to call it papulopustular. Papules are little red bumps, pustules are whiteheads, basically. And so patients on these drugs get these whiteheads and little red bumps on the face, upper chest, and upper back. If you look in the medical literature, you'll see that the severity can be quite a range. So some patients don't get any reaction, some patients get grade 1 or mild reactions, grade 2 are what we would call moderate, and then grade 3 reactions are severe. You can see the gentleman in the right upper corner here of this figure has basically some significant crusting on his nose that might actually be some staph bacteria, and I'll show you some photos of that as well. So, you know, these are pretty significant reactions, and we've learned a lot about them in the last decade. So one of the most important questions my patients tend to ask is, can I prevent it? Can we stop this acne-like rash from coming out? And the short answer is, a beautiful study was done back in 2010 by Dr. Mario Lacouture, who is one of the leaders in skin toxicities. And he basically showed that if you use a specific prevention regimen, you decrease the likelihood of having a moderate rash by about 33%. So only about 1/3 of patients will have a moderate or higher rash if they use a very specific prevention regimen. So the short answer is, can we prevent this rash? Most of the time. But the other important answer is that if we can't prevent it entirely, by using this prevention regimen, we can make it less severe. And so in my opinion, most patients should be on almost all of this prevention regimen anytime EGFR inhibitors have been started. But I will tell you, not everybody is aware of this paper or this data. And so oftentimes patients are not started on a full-on prevention regimen when they're given an EGFR inhibitor. And that's a matter of not only educating patients, but also educating the medical community. So again, that team of oncodermatologists that's out there in the country is working really hard to educate our dermatology and our oncology colleagues. So what does this prevention regimen include? Well, importantly, since these drugs cause breakdown of the skin barrier and severe dryness like we see in children with eczema, we need to minimize dryness. So hot water actually strips your natural oils from your skin. So when bathing or showering, we want to use warm or lukewarm but not hot water. You want to take short, not super long showers and baths. Always use gentle cleansers that are fragrance-free. You want to avoid a lot of botanical products, anything that can sort of be irritating to the skin. Soaps that are, again, moisturizing rather than stripping of the natural oils are better. We want our patients to apply bland, fragrance-free, boring, bland, thick moisturizers twice a day. So petrolatum or petroleum jelly is actually a thick ointment-based moisturizer. Most people don't like to smear Vaseline all over their body or petroleum jelly all over their body. But ointments are thicker than creams, and creams are thicker than lotions. So many patients are using lotions and they go on very easily, but they don't last long. So you at least want to stick with a nice, bland, thick cream. And there are lots of options for that. Other things that we can do to prevent this rash. We can, my screen is stuck here. We recommend that all patients use a broad spectrum high SPF sunscreen at all times. So again, these drugs cause phototoxicity or photosensitivity. And what's really important about this is that it doesn't necessarily cause a sunburn. But it actually caused the acne-like or pimple rash to be worse. So patients develop flares of the pimple-like rash on their face, on their scalp, on their neck when exposed to the sun. So for those patients who have fine, thin, or missing hair on their scalp, sunscreen and a hat are actually critical. Prescription topical steroids are recommended for the face, the upper back, and the chest twice a day. When you're going to start these medications, your doctor will know the appropriate strength, but we basically use a low-strength topical steroid for the face, upper back, and chest. For the face, and a medium-strength topical steroid for the upper back and chest. We do recommend that about twice a day. And then lastly, the prevention regimen that was described in this paper included the use of oral antibiotics that are frequently used for acne, doxycycline or minocycline in the United States. These medications are also anti-inflammatory. So they have an added benefit of reducing inflammation. They help keep that staph bacterial burden low, and they prevent the toxicity from being quite significant. So what happens if if your team isn't aware or you didn't know to ask these questions? What happens if you don't prevent the rash? If you don't start the prevention regimen right away, or if your doctor only wants to start part of it, the good news is reacting works well too. So this patient came to us not on any prevention regimen, but she had significant papulopustular eruption, and by putting her on that regimen, we were able to get her clear within a matter of weeks. So that's what we tend to do for the pimply papulopustular eruption. And I'm going to now walk through sort of the other things that EGFR inhibitors can do to the skin, hair, and nails to make sure everyone on the webinar has some pearls or tools that they can use for their skin as well. So again, these drugs inhibit some of the normal function of the epidermis, not just the epidermal growth factor in tumors, and they can cause this significant dry skin. So I found a lot of people minimize the significance of having dry, flaky skin like this, but again, it is so dry, patients develop eczema or eczema-like symptoms, and they can be maddeningly itchy. And so aggressive, thick, bland moisturizers at least twice a day can really help with the itch and the flaking. If the itch has progressed to the point where patients have inflammation, redness, or dermatitis, so as in the two photos on the left here, there's some redness between the cracks there and the eczema crackly-like picture. Those patients do tend to benefit from some topical steroids, a medium-strength topical steroid, just to turn off the inflammation. again, so one of the frustrations I have in taking care of some patients is that people say, it's just dry skin. Well, dry skin can really, really impact quality of life when it leads to dermatitis or eczema-like changes. And so, again, warm, not hot showers and liberal moisturizers are really your best friend. Skin fissures. So fissures of the fingertips and the heels can really hurt and really impair people's ability to do their normal life function. So typing, texting, cooking can be impacted by these painful fissures that affect the fingertips. These tend to be a later finding. And again, this is an inflammation problem. So we actually use strong topical steroids on the hands and feet of patients who are developing this inflammatory problem to try to reduce the inflammation. Thick ointment-based moisturizers are needed for sort of after each time patients wash their hands. So we treat this as severe hand eczema. And then lastly, for pain, when patients do have the fissures themselves on the fingertips, I recommend a skin glue. So there's lots out there about using super glue. Many patients just use super glue from, the hardware store or the grocery store. I prefer to use a medical grade super glue in hopes that it's better tested. I don't have any data to support that. But after hearing from many, many patients, the thicker glues tend to work better. And I am going to give the name here of a brand. It's about $4 on Amazon, but my patients have found the NextCare brand of the skin glue to be the thickest and longest lasting. But honestly, anything that works for you, that you paint in the cracks and sort of just leave it there and decreases the pain, I think is fine. But I do try to use the medical super glues over the standard super glue because many patients are on these drugs for long term, and I'd rather not have the chemicals associated with standard super glue going onto patient's skin for a very long time. Bacterial overgrowth. That Staph aureus overgrowth can be a real problem. So any of you with children might have heard of impetigo. So kids with impetigo get this yellow honey-colored crust. And that yellow honey-colored crust tells us that Staph aureus is overgrowing in the skin. It's more common in kids with eczema. And lo and behold, by affecting the skin barrier, we see the same honey-colored crust in our patients on EGFR inhibitors. It's not always this severe, obviously. It can actually be quite mild. And one of the other signs that you might have Staph aureus overgrowing is actually having a fissure or a crease. I think you guys can see my arrow here. A fissure in the nostril is actually a sign that Staph aureus might be overgrowing. So many of our patients will come in with their dry, scaly skin. They'll have a little bit of crusting and they'll say, man, it feels like I have a slice or a cut inside my nostril. And that tells me that the Staph aureus is really, really overgrowing. So what do we do to try to limit this? In the pediatric dermatology setting, we actually use bleach baths quite a bit. And so we employ these in our patients on EGFR inhibitors as well. I know it seems a little bit crazy, but it's actually no more significant than swimming in a chlorinated pool. So you use 1/4 cup of standard household bleach in a 40-gallon tub. So I trained in New York City, and I don't think anybody had a standard 40-gallon tub, but that's the standard size of a bathtub. So sort of just get a sense if you're using a giant soaking tub versus a mini standard New York City 1-bedroom apartment tub, you might have to adjust your dose. But that's about the dilution for bleach. And I just have patients soak in a tub of warm, again, not hot water, with a little bit of bleach for about 10 or 15 minutes, a couple times a week, to sort of just decrease the burden of bacteria on their skin. If you're sitting in the tub, you take a face cloth, you can dunk your head if you're able to dunk your head, again, because it's no more chlorine than a standard pool. Hang that face cloth right over your head, let it drip down, and it helps diminish the staph bacteria that's living in all our crevices. Your doctor may prescribe an antibiotic ointment called mupirocin that you can put on any open skin, and actually is also really good for clearing up those fissures inside the nostrils. But if you're not already on oral doxycycline or minocycline, your doctor may need to prescribe an oral antibiotic as well. So the patient shown here got a sort of a full court press. He would have gotten bleach baths, topical mupirocin, and oral antibiotics given the degree of crusting. Hair changes are one of the things that are sort of not significantly talked about, but can also impact patient quality of life quite significantly in patients on EGFR inhibitors and other targeted therapies. These drugs can cause hair loss. They can cause hair to be curly sort of overnight. They cause the hair to be brittle and dry so that it just doesn't grow as long. This is a patient whose hair is normally straight on an EGFR inhibitor with nice, tight, curly hair at this point. Also importantly, it can cause excess hair growth on the face to occur. Eyebrows can become quite rough and full, even in patients who normally have very thin eyebrows. So what we recommend for the hair changes in general, take a look at this guy's formerly straight, beautiful, tight curls. We recommend gentle hair care in general. Processing and coloring can actually lead to some scalp irritation, and they can also lead to breaking the brittle hair. But some coloring can be okay, and if your scalp is not inflamed, there's no harm in using some forms of coloring that are not as irritating. But keep in mind, if your hair is brittle and likely to break, any type of processing can make it even more brittle. And so some patients end up having to try to get a short haircut to also have their coloring. The cosmetic industry is complicated, but there are washes versus the chemical colors, and talking to your doctor and your stylist, particularly if your scalp is inflamed, is really, really important. But the overarching theme is it may be okay to color your hair, and I know many oncologists say that it's not, and a global statement like that is just not entirely accurate. So just ask your doctor and your stylist specifically if there's an option for coloring, if that's important to you. Again, the hair changes on the face can be quite significant with excess hair growth. So when you have excess facial hair, it's actually okay to use medications like eflornithine or Vanica, but it can be irritating in some patients, so we often follow it up with topical steroids. Laser hair removal is actually okay if patients want permanent hair removal, if they get excessive hair growth on the beard area or the chin. Electrolysis is okay as well, but if you develop irritation or inflammation, make sure you have your oncologist or dermatologist available to come up with some tips or tricks for how to manage it. Again, so this patient's eyebrows are quite, she calls them bushy, but quite full and coarse. The texture of her eyebrows was dramatically different and changed. And you can see here also that her eyelashes are quite long, which brings me to trichomegaly, or the overgrown eyelashes that happen in patients on EGFR inhibitors. Now, in some patients, they grow relatively straight, like her. They're pretty straight. You can see, though, that she does have some curling here way out at the edge. And in other patients, they're extremely curly. So this patient's eyelashes here are actually almost 2 centimeters long, almost an inch long, growing on his upper lid. And the trouble with these eyelashes, again, are that the hair is coarse and curly, and it can actually curl in and cause corneal irritation, scarring, and significant inflammation of the eyes. So this is managed simply by trimming. And that may be done at a salon, or it may be done by one of the nurses or doctors at the oncology office, or an ophthalmologist. Anyone who's willing to trim can trim. And some of our patients have gotten comfortable either having a spouse do it or doing it themselves as well. But keeping those eyelashes at a reasonable length so they don't curl in and scratch the cornea is actually pretty critical. Nail changes are also common, and they tend to be a later finding in patients on EGFR inhibitor. And they can include inflammation around the nails. So many patients talk about brittle and dry nails, but the inflammation around the nails can actually be really important in terms of pain and secondary infection. So if there's pus, as there is in this picture, your doctor most likely will want to culture it and see what bacteria might be growing. If there's significant inflammation, again, those oral antibiotics that we start for the papulopustular eruption or for the staph overgrowth can be very helpful. We do a lot of dilute vinegar soaks for patients who are having nail changes as well. And this is about a 1 to 5 or 1 to 10 dilution of plain household white vinegar, which is actually antibacterial. Now, very, very, very importantly, I don't ever recommend that people do vinegar soaks and bleach baths even in the same regimen. So if your problem is primarily hands and feet, you're a vinegar soak person. If your problem is primarily staph overgrowth or the pimple eruption, you're a bleach bath person. Never ever do both at once, because vinegar and bleach, when combined, make chlorine gas, it can be deadly. so pick what your biggest problem is and focus on that, but it's not worth the risk of ever implementing both of these interventions at the same time. Again, all of these problems of the skin are inflammatory problems. So the inflammation around the nail folds is actually also treated with high potency topical steroids. It looks infected. It looks like an infection problem, but it's actually an inflammation problem. So this photo here is inflammation. Only when there's pus or drainage do we worry about an infection. Sometimes excess tissue grows around the nail. So you can see here in this photo, this red granulation tissue here, that's what it's called. It's sort of an overgrowth of tissue that leads to worsening ingrown nails. So first and foremost, you want to treat the paronychia, which again was that inflammation around the nails. Sometimes we use something called silver nitrate, or this little stick in the office to sort of push back that granulation tissue. Sometimes we use cautery or heat to push it back. Sometimes we trim the nail or have to sort of cut part or all of the nail. I've had some patients with such severe involvement actually have their toenails just removed so that we could get the inflammation under control, but that can also be quite painful. So other things that everyone can do sort of preventatively or when they have a little bit of a problem here is use tape to pull the lateral nail fold away from the nail itself, and I'll show you a picture of how to do that. And then very importantly, wearing wide toe box shoes. So what the heck am I talking about here? If you look at most shoes, and I'm going to use these running sneakers here as an example, most shoes actually smush our toes together. And this is going to actually be important in our hand-foot discussion in just a minute as well. But even just take a look at these sneakers. The toe tapers to a point, and so inside the shoe, the toes get smushed together. And you look at this shoe brand here, which is actually the whole point of this shoe brand is actually to try to develop wide toe box shoes. You see that the toes can actually lay in a more natural or normal environment alignment. So if you take a look here, if this toe were to push against the side here, it sort of just pushes that skin over. So we don't want anything that's crushing our toes together. And then this tape trick actually involves putting a piece of tape here, wrapping it around the finger or toe, and sort of having the tension from that tape pull the skin off the edge of the nail. So when you do all these things together, when you treat the inflammation, you remove the granulation tissue with either cautery or silver nitrate, you tape the nail fold away, and you stop the problem of having the toes get smushed together by shoes, most patients can do pretty well without significant impairment of quality of life there. Sun sensitivity, which I talked about a little bit with regard to the pimply rash, again, it can be quite severe and significant. And importantly, the doxycycline or minocycline, the oral antibiotics that we use for all those side effects that I just talked about, also cause sun sensitivity. So patients really, really, really need to be very good about sun protection. So this patient actually took his golf gloves off for just about 5 or 10 minutes at the turn. And because he had not put sunscreen on his arms and hands because he had long sleeves and gloves on, just 5 minutes resulted in this significant burn. Importantly, when we look at targeted therapies, this photosensitivity is actually mostly mediated by the ultraviolet A spectrum. So the sun comes down to the earth, UVA, UVB, UVC is mostly filtered out by clouds. UVA actually penetrates deepest in the skin. And what's important about that is it's the UV, the SPF on your sunscreen tells you how much protection you have from UVB. For UVA, you need to look for the word broad spectrum in the United States. So you just want to make sure whatever you're using for sunscreen covers UVA, UVB. You want to wear a lot of sun protective clothing to just sort of get an extra boost. You want to make sure you're reapplying every 2 hours if you're outdoors, wearing a hat, again, because if you have thin or fine hair, even women with lots of hair, if it's thin or fine, if you've ever gotten a sunburn in the part of your hair on the top of your head, then you are at risk for getting a terrible flare of your pimply rash on your scalp if you go out in the sun. And very importantly, UVA can actually penetrate a lot of window glass. So there's some glass that blocks penetration of UVA, but I've had very ill patients who are on targeted therapies who were not going out and doing anything, but they were napping next to a big window on a beautiful day, and the UVA that penetrated the window glass actually caused their skin to flare. So broad spectrum, high SPF sunscreen every single day, reapplying every couple hours if you're outdoors, being aware that it needs to cover UVA, and sun protective clothing is really your friend. So key reminders when starting an EGFR inhibitor, Again, dry skin care, bathe or shower in lukewarm or cool water, not hot. You're going to apply a topical steroid daily to your face, your chest, and your upper back in most cases. You want to wear broad spectrum UVA, UVB, high SPF sunscreen at all times, bland, thick moisturizers, and consider oral antibiotics when you're going to start. So I think everybody should really get the topical prevention regimen. Whether or not to start oral antibiotics is a bit up to you and your doctor, because there are lots of reasons patients might prefer to just wait to see if they develop a side effect. So that is the end of this little part of the talk on EGFR inhibitor side effects. And I'm going to jump into reactions on the hands and feet to make sure we have some time to take questions at the end. Hand and feet reactions in cancer treatment they're a little bit famous. They're one of the most common side effects that patients, oncologists, oncology nurses talk about. And if you look in the dermatology textbooks and in the medical literature, people tend to put them all into one bucket and call them hand-foot syndrome. But I'm going to show you some photos today, and I'm going to argue actually that there are 4 buckets, and that not all reactions on the hands and feet are the same, and that the more we can start to learn and understand these side effects, the better we will be at researching them and managing them. So my 4 buckets, the details of them here are not really important. I'm going to show you some photos in a minute, are a very specific type of hand-foot syndrome that happens on the tops of the hands and feet, specifically from taxanes like paclitaxel, docetaxel, Abraxane. The classic hand-foot syndrome, or palmoplantar erythrodysesthesia, PPE is what some people call it, which is from classic cytotoxic chemotherapy. Hand-foot skin reaction from targeted therapies. This is our dose-limiting, very frustrating toxicity that's caused by many of the targeted therapies used in colorectal cancer, as well as other both solid tumors and leukemias and lymphomas. And then lastly, with the advent of immunotherapy, we see all sorts of immune-mediated or autoimmune diseases that can affect the hands and feet as well. So I tend not to put all of these things into one bucket. And so I'm just going to show you some pictures and give some management pearls so that as you embark on this, this cancer journey and go through all these different lines of treatment, you can sort of help yourself and your team understand, which side effects might be from which drug and how best to manage it. So again, dorsal hand-foot syndrome, or rashes on the tops of the hands and feet, happen very early with taxanes, paclitaxel, docetaxel, and Abraxane. Now these drugs are used for basically every type of cancer at some point in the course. They're not commonly used for colorectal cancer up front, but many patients will see them at some point if they have more advanced disease. They are associated with painful lifting of the nails, which can be quite impressive as in this case. And again, what's important here is it's on the tops, over the backs of the hands and the knuckles, rather than on the palms and soles, which I'll show you again in a minute. Most importantly, I think, is that there is a nice clinical trial that showed if you cool the hands and feet with ice packs before, during, and after chemotherapy, you can actually eliminate any significant nail toxicity and dramatically reduce the skin toxicity. So cooling the hands and feet starting 15 minutes before, throughout, and 15 minutes after a taxane infusion basically eliminates moderate and severe nail side effects and dramatically decreases rash. Now again, our medical oncology colleagues are wonderful. They're focusing on the whole body, but I've heard some of them tell me, oh, it's just the nails, where they've minimized the impact of that. And with that, I invite them to consider sort of ever banging their finger with a hammer. Have you ever gotten a bleeding underneath your nail? You can see how incredibly painful that can be. Well, when all 10 of your fingernails lift and become painful, it can make it very difficult to do your normal daily tasks. Changing diapers, washing dishes, typing on your computer, working as a surgeon, whatever it is that you need to use your hands for is very, very difficult when all your fingernails hurt. And ice packs can actually eliminate that significant toxicity. So very inexpensive intervention. While many cancer institutes don't do it as a standard of care, Amazon is fully aware that that chemotherapy slippers and mitts might be useful. But importantly, these are a few $100s, and bags of ice work just as well. So if you This is more what our infusion center looks like. What you don't want to do is put the ice packs directly on your skin. So I have patients sort of just put on thin cotton socks or thin cotton gloves, or just lay the gown over the hands and feet and wrap the hands and feet, or lay the ice packs on in whatever way is easiest for you. Again, any cooling is better than no cooling. So some patients just ask the nurses for a refill of their nice ice cold ginger ale cans and things like that. Any cooling is better than no cooling. Taking breaks is okay. Most importantly, don't heat the hands and feet. Get those big warm slippers off if you're on a taxane, because you can increase your skin toxicity. This is a patient who had significant toxicity before and after ice packs with cooling, so her skin got much better, but she wouldn't put the ice packs on her toes. She had her toes sticking out, and she actually blistered where the ice packs weren't. So this just helps to drive home the point. This particular toxicity from taxanes, it's still happening. We see consults for it every week, and it can be prevented with ice from the nourishment station. Hand-foot syndrome, the classic hand-foot syndrome, the one we hear about most frequently, the one associated with capecitabine or Xeloda and 5-FU, happens within weeks to months. It causes significant impact on patient quality of life. And again, understanding which drugs are causing these problems, especially when you're on regimens like Folfox, FOLFIRINOX, FOLFIRI, adding in cetuximab. As these regimens get more and more complicated, being able to pick out which drug's causing which problem allows your doctors to sort of only hold that drug if needed, or reduce that drug if needed. And so that's why I'm not a lumper here. I like to split out which drug is contributing to which problem. So the classic hand-foot syndrome affects the palms and soles. Patients often describe tingling and burning pain. They get well-demarcated redness and swelling on the palms and soles itself. Occasionally, it can be so severe they get blisters, ulcers, and wounds. Again, I show you these pictures primarily because it looks very, very different than the one that affects the tops of the hands and feet. And the mechanisms have to be different, and how we treat them also is different. Quite severe. This patient actually went to the emergency room several times for his hand-foot syndrome, which we were able to get under control with high-potency topical steroid ointments and doing some good dry skin care there. A less inflamed version of hand-foot syndrome here in a young woman. And importantly, again, anytime someone says it's just the skin, you can remind them that when the skin gets very irritated and open for long periods of time, patients can actually suffer from more significant infections. This patient was actually reported in the literature because they got a bacterial infection in the blood that ultimately led to them passing. So we want to keep the skin intact. I want to help our patients, have an annoying problem rather than a life-threatening one. So this is more what we tend to see with capecitabine or Xeloda hand-foot syndrome over time, just thickening and redness of the hands and feet. Again, that can be quite painful. So this patient was on Xeloda or capecitabine for 19 months at this point. So if you look in the literature, this problem has been studied for decades, and we're not that great at managing or preventing it yet. So we tend to grade it in the way shown here. Grade 0 means there are no skin changes. We use gentle skin care on everybody. Importantly, if you look at every study that's been done and all the analyses of those studies, one thing comes through as having evidence to support it, and that's that celecoxib, 200 milligrams twice a day, which is an oral non-steroidal anti-inflammatory drug, can actually prevent and manage the pain associated with capecitabine or Xeloda toxicity. Grade 1 is mild hand-foot syndrome. We add topical high-potency steroids twice a day in those cases. If it becomes grade 2, pain control is added in the form of, again, oral NSAIDs or other medications that are used for pain in collaboration with your doctor, like gabapentin or Lyrica. When it's severe, we generally have to hold the anti-cancer treatment until it drops down to grade 1 again, and then we sort of reinstitute therapies as for grade 2. So this continues to be a problem, despite the fact that many of the drugs that cause this have been around for many, many decades. So we got to continue to work on research here. And then hand-foot skin reaction is a significant problem that is different from hand-foot syndrome, both dorsal and palmoplantar hand-foot syndrome. And I'm going to show you some pictures about why and how this is different and how we approach it differently. Hand-foot Skin reaction starts within the first 2 weeks of targeted anti-cancer therapy. So usually patients develop scaling, swelling, redness, and then dryness and peeling. Often the pain is worse than what the hands and feet look like. So it's really important to articulate or tell your doctor how significant the pain is and how it impacts your quality of life. Patients develop these thick, tender lesions with or without blisters with a surrounding rim of redness. I'll show you some pictures in a second. They're most pronounced in areas with increased pressure and friction, and they're most common with drugs called multi-kinase inhibitors or targeted therapy. So drugs like regorafenib, sorafenib, these agents that can be added in patients with colorectal cancer as supplemental therapy, and they are used in other cancers of the GI tract as well. Regorafenib is the biggest offender, where 60% of patients will develop this toxicity, and 20% of them, or 1 in 5, will develop severe hand-foot skin reaction. It looks different than PPE or acral erythema or hand-foot syndrome, and that you get these tender hyperkeratotic calluses with red rims, very, very inflamed and thick. And actually clinically to dermatologists resembles a little bit psoriasis, which is an autoimmune disease of the hands and feet. So if you look in the literature and you say, what the heck do we do for this? What's been tried for hand-foot skin reaction? Knowing that it looks different than hand-foot syndrome, you'll see a bajillion studies, lots and lots of small studies, lots and lots of case reports and case series, lots of things have been tried, but the short answer is there's been no home run to date. And so we sort of take in all of this information as we approach our patients. And I'm just going to march through what I do for folks who are going to start targeted therapy and talk about how we manage hand-foot skin reaction in my clinic here at Dana-Farber. So before starting therapy, I recommend that someone examine a patient's hands and feet and talk to them about their activities and their hobbies whenever possible, preferably a dermatologist. So this is a patient who was referred to me for hand-foot skin reaction who actually just has athlete's foot. So treat anything pre-existing. It's not that often that oncologists are taking your shoes off and taking a look at your hands and feet prior to starting therapy, because again, they're dealing with talking about all of the side effects of your cancer treatment and all of the organs involved, and so just taking off the socks and taking a look at the hands and feet can make a big difference. Treating any fungal disease, treating any rashes or dermatitis, and then if there are big hot spots or big calluses, those can be pared down prior to initiating therapy, but not once on therapy. And that's actually really important. Depending on where you live and where you work, you may see that some patient information says that it's okay to go ahead and get pedicures. Those guidelines came out because patients wanted to get pedicures, and in general, they're okay before treatment. But anything that increases friction based on the mechanism that I just talked about is going to make hand-foot skin reaction worse. So pedicures and pumicing is okay prior to starting a targeted therapy, but once you're on it, we recommend against it. Everyone gets dry skin care. Again, bland moisturizers, warm, not hot water. And then urea cream is actually something called a keratolytic. Urea breaks down the thickened skin and sort of keeps the fingers and the hands and feet from getting thick calluses on them. So urea cream is safe and available over the counter to use twice a day. I encourage everybody to sort of avoid repetitive tasks or vigorous exercise with repetitive motion. So this patient here was a gardener, and so she was often out in her garden, raking and gardening, holding the same tools over and over again. We see similar changes on the hands of patients who cycle or who hold the handlebars of a bicycle over and over again. If you're going to be doing something like shoveling, here we are in the Northeast, raking, chefs, I've seen chefs have similar changes on the hand that holds the pan and on the fingertips of the hand that is used when dicing or cutting food. If you're going to be using the hands repetitively, lubricate the hands with petrolatum and then wear cotton gloves. So you're decreasing the likelihood of friction by having the hands be quite lubricated. This is a little bit more common when we're talking about the feet. So anyone who's going to do anything prolonged when walking or running, we ask them to pretend they're going to run a marathon. Lubricate your feet with a thick layer of petrolatum jelly. between the toes, around the toes, and eliminate the component of friction in anticipation of anything. So I've had patients who were doing well and then went holiday shopping all day long, and the act of walking at the mall all day long made their feet, this is actually the patient shown here, made his feet look as though he had just run 20 or 30 miles. So lubricate like crazy with Vaseline, wear well-fitting shoes. Again, remember the wide toe box. These are actually shoes that I wear running. You see how wide the toe box is so it doesn't squish your toes together. And then athletic socks. If you take a look, again, out there in recommendations, you'll hear a lot of things that say, wear cotton socks. If you think about using a cotton sock for going for a long distance run, anybody who has worn, who's gone for, runs of 5 miles or more, you will know that cotton socks are not the best choice, and athletic or technical socks actually handle moisture much better. Even things like wool are better. What do you wear to ski? So applying common sense here and looking on sockgeek.com, you'll find that rule number 1 when you're running is to actually keep the cotton socks out of the running shoes, because cotton actually holds moisture, and moisture, heat, and friction leads to blister, calluses, and hot spots. So where the medical literature falls short, we try really hard around here to consider every patient and apply common sense. So to minimize hand-foot skin reaction, use your dry skin care. You can use your urea twice a day. Avoid repetitive tasks or vigorous exercise, but if you're gonna do it, lubricate your feet and hands like a marathoner in anticipation of activity. Make sure your shoes fit well, wear athletic socks. And I know all of this because, again, I run the marathon to raise money for research here at Dana-Farber. And this is me in 2012 when it was 90 degrees and I blistered my entire sole. Heat and friction are a problem. Back when we had the monsoon a couple years ago, wet as could be, but cold, not a single blister. You can see I'm wearing my nice wide toe box shoes here. Using the right gear actually makes all the difference. And as a side note, for any of the gentlemen out there who might be treated with these targeted therapies, the same story is true for scrotal irritation. So we actually see hand-foot scrotum syndrome, and nobody likes to talk about it, but the scrotum sort of hangs down there, and when you're wearing boxer shorts and being active, the friction between clothes, the scrotum, and the legs can cause erosions of the scrotum itself. And so some of my happiest patients are those where we again applied common sense and said, how can we reduce friction on the scrotum? We recommend wearing a technical, athletic boxer brief, wick away moisture controlling boxer briefs. And many of my patients who have done that have had such great improvement in their quality of life. And again, that comes not from the medical literature, that comes from the running literature and how to decrease friction there. So another pearl for everyone here is that where the limits of medicine or evidence stop, it's always important to sort of just pause and say, what is the problem we're trying to address? What do we think is causing it, and how can we intervene? And that's where a lot of our recommendations come from a practical standpoint. We pull from our knowledge of eczema in children to manage the EGFR inhibitor side effects. We pull from our knowledge of heat, friction, psoriasis to manage the hand-foot skin reaction, because that's what it looks like. So for severe cases of hand-foot skin reaction, because of the way this condition looks and because of our knowledge of psoriasis, we actually use medications that are used to treat psoriasis. So oral retinoids, or a medicine called acitretin, has been around since the 90s, and it actually can help patients who have a lot of thickened skin or having a lot of pain, and allow them to get on their full dose of cancer treatment. So oral retinoids are something we use in severe cases, and we actually are studying the use of topical retinoids, so the topical psoriasis drug, to prevent hand-foot skin reaction. And your doctors can find that clinical trial on clinicaltrials.gov, because if you can't get here to be on the clinical trial, you may be able to try it out on your own. So in conclusion today, I think skin side effects are really, really common in patients undergoing treatment for colorectal cancer. These drugs affect the skin, they affect the hair, they affect the nails, they greatly impact quality of life, and they are associated with response to treatment. So again, those patients who are getting the worst side effects in the skin are the ones most likely to respond to treatment and the ones I want to keep on therapy. So we need to get these side effects under control. while there is some evidence out there for how best to do it, especially in the EGFR inhibitor setting, there's a lot of practical approaches that can be applied that are based on other conditions and on science to help improve patient quality of life and minimize the impact of these toxicities. So I think a team approach, including a dermatologist whenever possible, can help. I know there are not that many dermatologists out there in the country. There are even fewer dermatologists specialized in cancer patients, but reaching out and asking and emailing and working with your oncologist to find one can be tremendously helpful. And with that, I'm going to end with my friend Connor here, who reminds us alongside his mother that side effects of cancer treatment can really, really be a problem. So he's a leukemia survivor who suffered a complication of his treatment called graft versus host disease, which affected his lungs, and he ultimately had to get a bilateral lung transplant. Here he is on his last day of high school. He's 18 years old. He's tiny, and the medications he used to treat fungal infections for his lungs resulted in severe skin sensitivity to the sun. So he's had many, many skin cancers, even though he's only 18. And he and his mother work really hard to advocate for the continuation of research to not only find ways to cure cancer, but ways to cure it humanely. And I think the more we all work together and educate and advocate for improvement in managing side effects, the better we all are, because cancer and their side effects affects everyone. So with that, I'm going to open it up to questions. I think we have about 5 minutes or so left, 4 or 5 minutes.
Yeah. Thank you, Dr. LeBoeuf. That was an amazing presentation. So many great tips for patients before and during treatment to help manage their side effects. So thank you very much. I do have a couple questions that I can see that came through on my end. The first question, mineral versus chemical sunscreen. Is there one that's preferred for a patient that's undergoing EGFR inhibitor treatment?
Yeah, so I'm sorry I couldn't see the questions as we were going along. So mineral sunscreens include sunscreens where the active ingredient or the primary or only ingredients are zinc oxide or titanium dioxide. I prefer mineral sunscreens in general. They're considered physical blockers, and they basically reflect the sun's rays away. They tend not to be absorbed through the skin. So they do not have any other chemicals that might cause problems or any controversial chemicals. And so they are my top choice. The brand is less important. So everybody's skin type is a little bit different, but there are some great physical blockers that don't leave a white hue or that are slightly tinted depending on your skin type. And I will tell you that our Department of Dermatology here has about 40 full-time faculty, and every year we go through our sunscreen recommendation handout, and there's a big long debate and battle about what should be included because everybody likes different things. So I think the most important thing is to go ahead and look at the active ingredients and choose the zinc oxide or titanium dioxide based products, particularly for the sunscreen you're going to use every day or all over your whole body. I do use physical blockers or the non-mineral sunscreens when prolonged exercise, sweating are going to be important. So I do use the high SPF 85 or 100 with the waterproof option as well, particularly for prolonged things like a marathon where you're not going to be able to reapply necessarily and you're going to be out in the sun for 4 hours sweating. So in those cases, which are less often, the chemical sunscreens I think are fine. But the physical blockers tend to be less irritating and are definitively safe, whereas there's a lot of controversy about the safety of chemical sunscreens, which is well beyond conversation here. But zinc is a food element that we need to eat. If it happened to be absorbed, I still think that would be safe. So zinc oxide's my go-to.
That's great. So it sounds like if you're going to be out in the sun and exercising a lot, unable to reapply a chemical every now and again is okay. Otherwise, for daily use, a mineral is preferred.
Totally. And if you're going to tell me that you're not going to wear it because the mineral is too thick, then I would say sunscreen period is the most important. What type is second most important? So use sunscreen, and if the only thing you can tolerate is a chemical one, go ahead and use it. There is no definitive data that it's harmful at all. I just know that it's a point of controversy. So if you're concerned, go with physical blocker, but sunscreen of any type is most important.
Great. Okay, that's helpful. Thank you. Let's see, what else do we have? Have there been any definitive skin toxicities related to immunotherapy treatments? I know you mentioned it earlier, so I think this question came in previously.
Yeah, so immunotherapies cause any and all immune diseases of any organ. So they essentially can cause any immune-related dermatologic side effect, which is overwhelming, right? They basically cause the whole field of dermatology. So what we do see most often are eczema-like reactions, psoriasis-like reactions, and then a specific type of rash that looks like a condition called lichen planus. So they do cause a lot of rashes in patients. 30 to 40% of patients will develop a skin side effect. They cause itch in about half of patients with or without rash. So that again would be a whole 1 or 2 hour lecture on what immunotherapy causes. But as we start thinking about combination therapies, I just invite oncologists and dermatologists to take a look at the skin and say, what normal skin condition does this resemble? Because the immunotherapy activates the immune system and it turns on every possible skin condition that can exist.
Okay. I think we have time for one more quickly. What about exercises like yoga and specifically heated yoga? What are your comments about participating in that?
So it just depends on what your cancer treatment regimen is at the time. And heated yoga where your whole body's sweating, I wouldn't recommend it right after getting a taxane, again, because the toxicities are associated with heat. If your hands and feet are bothering you, but the whole room is hot, and you're doing yoga where there's not significant friction, I would sort of just recommend cooling the hands and feet off right when you're done. So sort of like ice bath them, just to turn off the inflammation. But for the most part, your body being warm is fine. It's the heat and friction on the hands and feet themselves on targeted therapies that are a problem.
Great.
What things that are good for your mental health are also good for your skin. So they help to reduce inflammation. So do your yoga.
Great. Awesome. Well, thank you so much, Dr. LeBoeuf. Great presentation, a lot of really useful information. And yeah, we really appreciate your time. Thank you so much to all the listeners who joined us live. And again, the session has been recorded. We will update it to the Fight CRC website. So please check back later today and you can find it there. Thank you so much, Dr. LeBoeuf.
No problem. Thank you so much for having me.
Have a great day, everyone.